All right. So good morning, everyone. We are going to get started just so that we can stay on a track of time. I'm sure we'll have people joining us. I know everyone trickles in for early morning Zoom meetings. But thank you for everyone who is joining this morning. This is session 3 of the Regional Summit. I know many of you have been with us the last 2 sessions. So we're going to keep the momentum going, continue our conversation on equity and local government. This morning is going to be on health equity, which obviously, as we are in the midst of a ongoing pandemic, is something that a lot of us are continuing to think about, how our social services and health services continue to support a lot of our vulnerable communities. So I am going to quickly provide some housekeeping that you may know, and if you do, bear with me. The meeting is being recorded, so just please be aware of that. And the recording will be made available after this session as well. So if you would like to share it out or watch again, it will be available. You have entered the meeting muted. We obviously, with a big group like this, it's ideal to have everyone muted unless there's something that you need to say. Please note that if you would like to speak, you will need to unmute yourself, but we will also be monitoring the chat box. So at any time, feel free to put comments or questions into the chat box. We will have a specific period of time for utilizing the chat box and talking through those questions later on in the session. If you need captions, those are also available. They're not turned on, so you will need to turn on the captions. You can do that by going to your taskbar, which should be at the bottom of the top of your screen. And there will be an option either on the taskbar or with the 3 dots that says close captions. And once you select that, the captions should be on. I will note that the captions are about 85% accurate. We are talking about some more technical topics, so there may be some challenges with translation, but for the most part, they will definitely be helpful if you're having hearing issues. And if you're having any bandwidth issues, you're working from home, broadband challenges, you can connect to the audio by your phone, and that information was also sent out in your confirmation email to join by phone. So those are our housekeeping items for today. One note to just say a big thank you to our sponsors for the event. They've been great partners, ongoing, most sponsoring this year's summit and other years' summit as well. So thank you to Electricities, Local Government, Federal Credit Union, and Bang the Table. And I will now turn it over to Mary Warren, who is the director of our Area Agency on Aging at Triangle J, to provide a little welcome to everyone.
Thank you, Elena, and thanks to all who are joining. It's my pleasure to kick off today's discussion where we're going to be exploring equity in healthcare and in health and well-being for all, but especially those who are most vulnerable within our communities. This pandemic has highlighted a lot of underlying inequities. For example, in our Latinx and African American populations, they continue to be much more likely to contract the virus, even as we are desperately working to provide outreach and education to try and reduce that impact. Our previous views on what is an essential worker are clearly in need of an update as we think about solutions for our already strained direct care workforce and how dependent we are on our supply chains and things that make for everyday life comforts. Our ongoing rates of infection in long-term care facilities, as well as other healthcare institutions, have really highlighted our lack of overall preparedness, and we don't really have a very coherent system for responding to an extended crisis such as this. You know, there are other struggles within our communities, such as racism, ageism, individuals who've lost their jobs and income, others struggling with social isolation and difficulty with just meeting everyday needs. And so all of these were here, but they've really come to the forefront, especially for those in our communities who haven't shared equitably in our region's overall prosperity. Meanwhile, we collectively can't even seem to agree on certain public health interventions, such as whether we should wear a mask or not. So how can we really ever hope to change the system of care and services and support so that there's a desirable level of health and well-being that's attainable for all. So fortunately today, our speakers can help offer us some solutions and a better pathway forward. And I think if this pandemic is showing us anything at all, it's emphasized our interdependence on each other and how we all need to be invested in understanding and addressing these issues going forward. So I'm very happy today that we're going to explore this topic. And with that, I'm going to now turn it back over to Elena to provide a special recognition and to introduce today's speakers.
Thanks, Mary. So yes, before we get started with our speakers, I do want to provide one staff recognition. So for those of you who have been at the Regional Summit in past years, we have tried to provide staff recognition for individuals who are celebrating special milestones with our organization. So today we wanted to recognize one of our staff from the Area Agency on Aging who is celebrating 5 years with our organization. Chris O'Keefe, who is on the call. We can all give some claps and virtual high fives to Chris for 5 years at TJCOG. She's the coordinator of the Chatham Orange Community Resource Connections for Aging and Disabilities. So some of you may have worked with her in the past, and if not, I encourage you to reach out. She is a great resource for those who are in Chatham and Orange County. So congrats to Chris for 5 years with TJCOG. So with that, I'm going to introduce our presenters, and then I'm going to turn it over to our first presenter, Brianne, who was going to kick off our presentation. So first, today's presenters, we've got a great lineup of some really smart and talented folks to talk to you this morning. Brianne Lita McDonald is a project director at the North Carolina Institute of Medicine. Most recently, she led the Healthy North Carolina 2030 Task Force in partnership with NC Department of Health and Human Services and the Division of Public Health, which developed a common set of public health indicators and targets for the state over the next decade. Prior to this role, Brianne worked as a public health analyst at RTI International, where her work included evaluating state demonstrations under the Centers for Medicare and Medicaid Services Financial Alignment Initiative and providing technical assistance to administration for community living grantees who offer services to people with dementia and their caregivers. Corinda Roebuck is the interim director of Chatham Organizing for Racial Equity, and she's also one of the co-chairs of the Chatham Health Alliance Equity Subcommittee. Corinda was born in the Bronx and moved to Atlanta, Georgia before landing in North Carolina. She is a certified nurse midwife and a community organizer. She currently serves as the interim executive director of Chatham Organizing for Racial Equity, or also known as CORE, a county-level organization seeking to dismantle structural racism through education, organizing, and reconciliation. She also serves as co-chair for the Chatham Health Alliance Equity Subcommittee. In her previous life, she was a medical anthropologist after graduating from Davidson College and UNC Chapel Hill. Her entire healthcare career has been dedicated to serving women in marginalized communities. She now lives in Chatham County with her husband and 2 boys for 15 years. And last but not least is Michelle Wright, who is the Equity and Community Engagement Initiatives lead for the Chatham County Health Department. Her role includes developing internal equity strategies, serving as a community liaison, and working with faith-based communities in the Chatham area. She began her education in developing equity strategies at the wonderful Winston-Salem State University and has made this an integral part of her work in all of her endeavors. So we have a fabulous lineup, and I will not take up any more time speaking, so I'm going to turn it over to you, Brianne. I'm going to stop sharing.
Thank you so much. And I really appreciate having the opportunity to talk to you all this morning. I'm going to share my screen and make sure that you can see that. All right, is everyone able to see the presentation? Okay, perfect. So I'm Brianne Lita McDonald, and I'm a project director at North Carolina Institute of Medicine. Just for those of you who aren't as familiar with NCIOM, We're a quasi-state agency. We were chartered by the General Assembly in 1983, and we do all sorts of work on health issues that are important to the people of North Carolina. And we do studies on issues at the request of the General Assembly, state agencies, health professional organizations, and our board of directors, which is appointed by the governor and Senate and House leadership. Okay. So how healthy are we as North Carolinians? North Carolina ranks 37th out of 50 states and DC in overall health outcomes. This is from our America's Health Rankings in 2019. When we look at different health outcomes, we're 39th in infant mortality rates, 36th in premature deaths, 36th in adult obesity, 38th in adult diabetes, 32nd in cancer deaths, 46th in disparity in health outcomes based on educational status. So we aren't really getting past the bottom half of states when we look at some of these health outcomes. And behind those statistics, we also have many disparities in outcomes when we look across racial and ethnic groups and across geographies in our state. So with infant mortality, African-American babies are 2.4 times more likely to die than white babies. When we look at diabetes mortality, American Indians are 2.4 times more likely to die than whites from diabetes. And in geography, life expectancy changes by race and by what counties we look at in North Carolina. This map highlights the large range in life expectancy across the state, with the lighter coloring being the greater life expectancy. And when we drill down within counties, we see zip code to zip code, those disparities exist as well. So we're used to hearing about how clinical care impacts our health outcomes. And we also often think about the types of behaviors that might impact our health outcomes. But we're now waking up to the impacts that the social and economic factors have. In fact, according to this model, they have the greatest impact on our health outcomes, at 40% impact on health outcomes, and also our physical environment. So these are things like education, employment, income, family and social supports, community safety, our air and water, and access to housing and transportation. And those issues impact on the behaviors that we're actually able to partake in when we think about healthy behaviors. And Elena talked about our work on Healthy North Carolina 2030. And I just wanted to point out that this is the state level public health indicators for the next 10 years. And the state is really looking at what are these social and economic factors, physical environment factors, health behaviors, clinical care, across this broad spectrum. So there's really interest there, things like poverty level, unemployment, reading proficiency, severe housing problems, and access to healthy foods. So then we think, how do we make an impact on these social and economic factors, physical environment issues? It's going to require working together in many new ways across the existing boundaries and silos that we have in our society. It can't be the efforts of one particular sector like hospitals or payers or public health. It has to include community member input into that process. So NCIOM convened a task force and developed recommendations about something called accountable care communities. This is a concept, not a specific hard and fast model, but we define accountable care communities as addressing health from a community perspective. ACCs, as we refer to them, bring together a coalition of cross-sector stakeholders that share responsibility to address the drivers of health while reducing or holding steady health spending. The task force was convened in 2018, and we had co-chairs Secretary Mandy Cohen, Ruben Blackwell, Ron Paulus, and Miles Atkins, who's the mayor of Mooresville. We were supported by the Kate B. Reynolds Charitable Trust and the Duke Endowment in this work. And we produced, with the task force, 24 task force recommendations to support the development of accountable care communities in North Carolina, and a guide for communities that are interested in developing an ACC. I do want to point out that Mary Warren was one of our task force members, so glad to be here with Mary. So our purpose in having this task force was to develop recommendations on how community agencies and healthcare providers can partner to share responsibility for the health of communities through collaborative and integrated strategies to promote health. And our vision as a task force was that communities across the state would convene stakeholders in sectors relevant to health-related social needs. And that's kind of a term that we use to talk about those social drivers of health, health-related social needs, to develop and implement accountable care communities to improve health outcomes, strive for health equity, and reduce healthcare costs by addressing many of the key drivers of health. And of course, needs are going to vary across communities. So we think about how this model brings together all sorts of different partners across sectors. So we have traditional healthcare that focuses on preventing and treating illness. We have community-based partners who focus on creating the conditions that are necessary to be healthy. And then we have those who purchase and pay for healthcare, among these many other potential partners, including public health, social service organizations, community-based organizations, and local government. So what are the natural interests of all of these potential participating partners? So when we think about community members, they have an understanding of the issues that they're facing in their community and a desire to have a voice in what directs the actions that are taken in their community. Local health departments have an overall mission to improve community health, and they have a charge to do something called a community health assessment every 4 years, and we'll talk about that in a minute. Health systems, hospitals, and other care delivery organizations, an ACC seeks to transform how healthcare is delivered and understood, so they have a natural interest in participating. Human service organizations are uniquely positioned to be a bridge between the community and the traditional healthcare organizations. Business needs healthy employees and to control the costs of healthcare, health insurance that they provide to their employees. And other sectors like education, law enforcement, and housing have the specific expertise that's needed to drive the changes that might be needed in the community for better population health and well-being. So we see that there are about 9 core features of an accountable care community. Those are, and I'll give a brief description of each of these, an assessment of community health, education and advocacy, having a screening tool for those social needs, a referral process to help people to meet those needs, a navigation of services that might meet those needs, a tracking system for how to track whether people receive the types of services that they might need, outcomes data and analysis to see whether there's actually improvements in community health, a financing structure for that partnership, and a governance structure for the partnership. So first we look at assessment of community health. As I mentioned before, every public health agency is required to do a community health assessment every 4 years, and also nonprofit hospitals are required to do a community health needs assessment. Oftentimes those are happening simultaneously together or in partnership. So this is a way that the community lets the public health organization know what kinds of needs are out there. In the past, there's been less acknowledgement of those social drivers. When we looked back at the 2010 and 2015 community health assessments, only 17 of North Carolina's 100 counties prioritized a driver of health, a social driver of health. However, that is getting a lot more attention now. So once there's data on community needs, an ACC or a cross-sector partnership will need to prioritize their work. So the prioritization process would involve looking at what's the level of that need in the community, what's the capacity within the community, what's already happening around that type of issue, the political will and the public will behind addressing that, equity. Are there issues that would address those disparities that we think of in the population, and what kind of existing efforts are out there? So as you select a topic or prioritize something, of course you'd need to reevaluate if you need to bring people into that partnership to make sure that you have the expertise and the voices at the table to really speak to how to address that particular issue. Then we think about education and advocacy, and this is looking at how a cross-sector partnership can have a voice in advocating for local policies and communicating with local government agencies about how what the health effects are of the different policies. So again, we often don't think about the health effects of transportation or housing policy, but we have the concept called health in all policies, that those policies really do all impact the health of our populations. So I'm going to point out a few of our recommendations as I go through, just to point out where some things would be maybe more relevant to this group. So when we think about education and advocacy, we look at our recommendation 2.2 for accountable care communities to evaluate the effects of any sort of ACC-related programs and activities on the health equity of the communities they serve. And for generally county departments in all sectors to evaluate the health equity of programs that include community members and human service organizations in that process of that health equity assessment. Another core feature is a screening tool. So a questionnaire to evaluate the health-related social needs of community members. So the North Carolina Department of Health and Human Services has developed a standardized screening tool. It's going to be required for individuals who are enrolled in Medicaid once the Medicaid transformation happens with the prepaid health plans. However, they do encourage human service organizations and other healthcare providers to use this assessment. It looks at food, housing, transportation, and interpersonal safety needs. So really trying to standardize what those questions look like in a pretty succinct way, and so that it can be familiar to people. Then we look at and we combine here the core features of a referral process, navigation of services, and a tracking system. So again, a referral process would be how you can refer clients or individuals for services that can help meet their needs. Navigation of services would be assisting clients who have trouble accessing community services, and then tracking system to capture information about whether those needs were actually met. So in North Carolina, we have an exciting new system that is developing and developing even faster during the pandemic is NC Care 360. I think a lot of you are pretty familiar with this. It's exciting because it's the first statewide system of its kind. If it is as successful as it possibly could be, it's definitely a fantastic resource and would standardize that ability to refer for resources and navigate that process for individuals. So related to this, related to this core feature, we look at recommendation 4.3, which is that accountable care community partners should use that standardized screening tool and NC Care 360, and look at the other optional domains that North Carolina Department of Health and Human Services has other questions that might be applicable in certain communities that they didn't include on that shortened screening tool, but are available on their website. And then local health departments, should identify unmet resources, resource needs, and use NC Care 360 to refer and navigate individuals who have needs. Then there's outcomes data and analysis. So there's a concept called results-based accountability, probably many of you are familiar with, that looks at how much did you do something, how well did you do it, and is anyone actually better off? Sometimes we, I think, get into the habit of putting in programs that we think are going to help, and then not evaluating whether or not that successfully met the needs that we were meaning to meet. So this is actually trying to evaluate what is needed and are we actually meeting those needs. So you can screen for health-related social needs, things like how many people were screened, how many people screened positive for needs, how many accepted referrals to community resources, and how many received those services. And then it'll be interesting to see in that NC Care 360 data that's collected, what types of needs are out there that are not being met. What could potentially an accountable care community or a cross-sector partnership start to focus on to meet those needs in the community. And then when we look at the needs in the community, again, looking at access to transportation, food deserts, unemployment, and overcrowded housing are potential ways to assess the data from the community. And then you can also assess the process. Were there staff that were trained on client and patient needs assessments? Were there client and satisfaction with the referral assistance? It's important to evaluate that data, both for understanding whether you're meeting those needs and also potentially for the financing of this partnership, to be able to have that success that you can say, this is something that is meeting needs in the community and potentially improving health. That is something that can lead to future funding opportunities. So financing is looking at the return on that investment and developing financial models to support service delivery of clinical and non-clinical services. In the short term, an accountable care community style model might need funding to develop the partnership, right? It's a time-consuming process. It involves a lot of partners, community members, and stakeholders. There might need to be legal counsel if there's a agreement, like a MOU developed. And partners might require some technical assistance that would require funding. In the long term, that return on investment should be used to negotiate with local government, businesses, healthcare systems, and insurance providers for payment of services that are needed in the community. One recommendation in our report that's related to this is funding for local accountable care community implementation, recommendation 6.2, that local governments should consider using local tax revenues to support accountable care community style activities. And then we get to governance. So having a collaborative organization in accountable care community should have a shared governance structure that has shared decision-making, shared risk, and shared reward with all partners. So partners need to have a strong understanding of what their roles and responsibilities are in that collective structure. And then that might involve, like I mentioned, developing written agreements or memorandum of understanding to define those shared goals, the structure, and the rules of an accountable care community, and what the commitments of those individual organizations are. So I want to bring it back to authentic community engagement. I think this is the most important thing I want to emphasize today, is that this type of cross-sector partnership should involve the community and be more than informing community members about what they're going to have done in their community. These ACC organizations need to work with the community to establish trust and share power with community members. One organization I like to kind of point out as a great example of this is Collaborative Cottage Grove and Greensboro, where residents are compensated with a small stipend, a meal, and childcare to acknowledge the time and effort that they take in leadership in that collaborative and the efforts that they put in out of their own time. So related to the governance, we have two recommendations. Recommendation 2.3, that accountable care community partnerships should work to develop a common language, common definition of terms, and common metrics to promote effective collaboration across sectors. So this kind of speaks to the fact when you bring together different sectors, that the language we use within our own sectors might not match. The words that we use might not be understandable to everyone. So having that common language of when we think about assessing or financing, that's really important in the partnership. And then in recommendation 2.6, that local community coalitions seeking to develop an accountable care community should be aware of and understand the regional implications and can be competing regional concerns of an ACC partnership whose work crosses boundaries of more than one accountable care community. So when we think about all the different types of regional structures we have in the state for housing and Medicaid and all sorts of things, that those cross different boundaries, and depending on the size of an accountable care community, those might be issues that need to be, that attention might need to be paid to. I do want to point out that North Carolina Department of Health and Human Services is planning for the pilots called Healthy Opportunity Pilots through Medicaid. This is currently on hold, but it is an idea that is an ACC style model that will test the impact of providing evidence-based and non-medical interventions related to housing, food, transportation, and interpersonal safety to individuals enrolled in Medicaid who have high needs. So the pilots are going to operate in 2 to 4 regions of the state, and funds can be used to address those needs. It's kind of its first of its kind in any state, being able to use Medicaid funds to do this. And we're hoping that it can be a model to see what types of impacts can be made in a community or in a population with providing these services. Selection of the lead pilot entities is on hold due to the pandemic, but I know within the Triangle J region that there is at least one potential lead pilot entity that tried to become, and I don't know what their status is. So this is just a confusing looking graphic to show you that the core features that I told you about, a lot of them are already being addressed in different ways, or maybe specifically to the population enrolled in Medicaid. So we have an assessment of community health with community health assessments. We have a screening tool, the referral process through NC Care 360, navigation of services through NC Care 360, and Medicaid Managed Care program that will be with Medicaid transformation, a tracking system of those needs in NC Care 360, outcomes data and analysis for individuals enrolled in Medicaid, and financing through Medicaid as well. So any community can form an accountable care community. We have several examples of models that are kind of transitioning or looking kind of like an accountable care community or a cross-sector partnership in the state. And they could come from existing groups that do similar work. They can come from local health departments that are natural leaders. So looking at like Cabarrus Health Alliance, community organizations can spearhead, and health systems are very interested in this work as well across the state, as well as tribal governments and tribal communities. So I do want to acknowledge the potential barriers and challenges in this type of work. Of course, the distrust from community members based on historical injustices, and that highlights the need and reason for that authentic community engagement and partnership and leadership from community members. Identifying champions and key leaders, because really this is work that is difficult and time consuming and requires someone to be that champion. Overburdened partners who are already doing a lot of work, of course, as we're in the midst of a pandemic, thinking, about that burden is very significant. Funding issues, siloed interests, and agreement on priorities and strategies as a partnership comes together and tries to determine what to work on in a community. I also want to point out that we have the guide for communities that are interested in starting an accountable care community with some information and lots of resources in there. That's available on our website, nciom.org. And that's also with our report on there with the recommendations. So that's it for my presentation. And I think I'll pass it back to Elena.
Thanks, Brian. There's one question I want to make sure is answered.
Sure.
How can we review the screening tool? Is that available in the guide?
I think that we have a copy of it in the guide. If you go to DHHS's website, or if you Google health, maybe social determinants screening tool for DHHS, I think you should be able to find it there. And on their website, they have a separate document that has all of the different optional questions that you could add in different topic areas.
Perfect. And we'll make sure to include at least a link to the general tool when we do follow up from the event. Awesome. Well, thank you so much, Brianne.
Sure. Let me stop sharing. Sorry about that.
No, you're fine. So we're going to shift from a little bit more of a state level view to a local view. And I'm going to turn it over to Corinda and Michelle from Chatham County to talk about their approach to incorporating equity into some of their health work. So it looks like Michelle is sharing the screen, and I'll turn it over to both of you.
Thank you. Can everybody hear me? I just want to make sure I unmuted myself. Great. Yeah. Hi, everybody. Again, I'm Corinda Roebuck from Chatham Health Alliance, and I'm here today with Michelle Wright to talk to you about the Chatham Health Alliance itself and the steps that we're taking towards achieving equity in Chatham County. A little historical background: the Chatham Health Alliance has been around since 2014 and formed as a group of community and agency members to determine health priorities and action steps from the 2014 Community Health Assessment. The Alliance itself is a member-led, broad-based organization consisting of individuals and organizational members from the community. Oh, there you go. Thanks, Michelle. So our origin story, about the equity subcommittee specifically, the need for an equity subcommittee was realized during the 2018 Community Health Assessment process. The assessment itself was a collaborative effort between UNC Chatham Hospital in Siler City, Chatham County Public Health Department, and the Alliance itself. While analyzing the disparity data of this particular assessment, it became quite evident that there was a need for an equity subcommittee. And in order to achieve the equitable outcomes that we had identified with these health priorities, the collaboration determined that we needed to do some changes in the Alliance's infrastructure and community engagement. So the equity subcommittee itself, if you want to switch, thanks, is led by members of the Alliance. And we have 2 co-chairs and a health department liaison who acts as a facilitator. As other Alliance subcommittees change to reflect the identified health priorities of each community health assessment, we've determined that the equity subcommittee itself will remain as a standing committee with the purpose of affecting equitable change in Alliance infrastructure, community engagement, and developing organizational equity standards. So our strategic planning began last year using the RBA process that Brianne had mentioned, the results-based analysis, and we landed with 4 goals in all. And our first goal is to diversify Alliance membership and going beyond data-driven targets. So our strategies are listed with each goal, and that which is in bold are things that we've already initiated. So for goal 1, we've identified strategies in which we can support Black, Indigenous, people of color spaces and build a sense of belonging within the Alliance by holding future meetings in these spaces. For example, we have our county fairgrounds, which is Black operated, and we have been talking about providing, holding Alliance meetings in places such as these. Our next goal is essentially developing, strengthening, and expanding our equity lens through our equity trainings and education that we can offer. So we've begun racial equity trainings with a local organization called Chatham Organizing for Racial Equity. These trainings are free for all Alliance members, and it's a 4-module training series, which is an introduction to equity, where participants start with equity fundamentals. They get a review of equity terminology, and then we move into a historical examination of racism and the current implications of that history today. The 3rd module does a dive into using your sagacious mind to reveal power dynamics and the power of biases and how that affects your everyday life. And lastly, participants will begin to explore disparity data and outcomes and how to use this information in their own strategic planning within their own organizations. So goal 3 is the actual application of what we discussed in goal 2. And this is happening within the Alliance itself. So this is where we use that developing equity lens from goal 2 in all aspects of Alliance activities. Currently, we are teaching our members of the equity subcommittee, we're teaching them how to serve a dual role on other Alliance subcommittees by purposefully maintaining that equity lens, especially as we are moving forward and creating action plans for the identified health priorities. And our 4th goal is the application of the developing lens from goal 2 again, but actually supporting members to use that lens and to carry that lens forth into their own organizations with support from the Alliance. Because we recognize that we play a significant role at the Alliance in collaboration between members and member organizations. And so we see that we can curate this equity toolkit for use with other member organizations. And so we seek partnerships with member organizations like the Chatham Organizing for Racial Equity to actualize this equity work. And I'm gonna hand it over to Michelle now.
I realized that I'm not as good at working the slides as I thought I was. But I thank everybody for their bearing with us as you listen to Corinda beautifully explain our goals and our strategic plan. So what I'm going to talk about now is integrating health and equity. And so I have a couple questions on the screen. Where does equity belong in your organization? And the truth of the matter is that equity belongs everywhere in your organization. There's nothing that should be taking place that doesn't have an equity lens and equity framework. And so equity should be integrated into the processes and structures of every single thing that you do within your agency or organization. While we do have ourselves organized as an equity subcommittee and we are a standing subcommittee, we realize that we are structured in these ways currently because we are trying to move towards that place in equity where we're doing it seamlessly. The goal is that we will operate in a way where this is the norm and not something that you have to continuously remind yourself about, in a sense. The second question is, what is the relationship between health and equity? And I'm going to bring up something that I think everybody knows about, the social drivers or determinants of health. So when we think about the relationship between health and equity, we're looking at how different structures affect outcomes for various populations. I tend to use the term marginalized populations versus minorities. And we use the words marginalized because we can break that down into understanding that when you are a part of a marginalized population, you are a member of a group that has been othered and has been pushed to the margins. And so we want to shy away from having that relationship between health and equity sit in your individual identity. So we don't want to say that because you are Black, you will have this outcome. Because you are this, you will have this outcome. We want to make sure that we are understanding that it is the interaction of a system and its structure that creates these outcomes for these marginalized communities. And so the relationship between health and equity really sits in how people are able to access services, resources, and different opportunities based on how systems interact with them, based on policies that are historical that still have current impacts. We are looking at all of these structural things. We're not talking about individual choice. We're not talking about genetics or different things when you talk about specifically with health and something that you may have inherited in terms of a prevalence for cancer, this, that, and the third. We are talking about how if I am born in a certain community, if I receive certain things, if there's pollution, if there's a higher rate of policing, all of these different things in my area, in my community, and then I'm also a part of a group that is additionally targeted, we are looking at what that means for my life outcomes. And so that's the relationship between health and equity, and understanding how these two things are interrelated, they interact, they're positively correlated, I guess, to use more technical terms. So the third question is, what does this look like in a community space? So essentially, talking about equity in a community space is talking about shifting power. It's talking about, or it looks like understanding that who I am in a public health space, who I am with an education in ... In a community space, equity looks like understanding that I am the expert, that the community members are the expert of their experience, of how they are interacting with systems. It's not about what we can see on paper. It's about applying that lived experience to our understanding of the things that we can see and kind of verify with data. It also looks like us understanding what we mean by community engagement. A lot of times I think that where organizations across the board fail by trying to have equitable process or practices or in community engagement is that we bring people in on the back end. We have an idea about something that's going to solve a problem. We can see the numbers and we want to fix it because that's what we do. We're fixers, right? We want to fix people. We want to fix the fish and the and the lake and everything. I'm not sure if everybody's familiar with that metaphor, but you know, we want to fix all these different things. And where we fail is that we are coming in without the background knowledge of how people are living. We are coming in without an understanding of that experience and how it is expressed, because I may be experiencing oppression or structural racism. I may be experiencing poverty. I may be living in different situations, but how am I navigating that? What are the protective factors in my culture? What are the strengths that are within my community that I am utilizing? Because we know that even though certain things drive your health, we can openly see that everybody's not failing. Every single person is not dying. So what is it that we really don't know and understand about doing this work in this space and where resilience really sits within different communities? So doing equity work is about understanding how you enter into communities with certain levels of privilege. It's about understanding their expertise. And it's also about recognizing that there is power already sitting with people. So we're shifting power dynamics. We're not actually pouring power into people. We're not actually assuming that we have a level of control or a level of power that really doesn't exist. We are living within a system that has created structures and beliefs that kind of perpetuate certain things. But we have to be very aware that people have power, and we are here to help figure out how to break down those barriers for them being able to use it and reach their optimal level of health and well-being. I can ramble on so much. It's my favorite topic. I'm going to take us to the next slide. So some of our initiatives within the Chatham Health Alliance are also things that are collaborative with the Public Health Department because they're very intertwined entities. So one of my absolute favorite things is the community conversations. And this is created by the World Cafe model. If anyone's familiar with that model, this is something that really focuses on not just doing focus groups, not just pulling on people and not keeping them engaged. It's an opportunity to go and work with communities to provide them with an open space and forum to lead a conversation. It's lightly facilitated, but it really focuses on not entering into the space as an expert, allowing people to be experts in their communities, allowing them to share. And it's not a space where we are correcting people if they have maybe an idea or a perception about something that may not be in line with our organization or so forth and so on. It is a true opportunity to practice those observation skills and join into the conversation without taking over the conversation. And so it's a really good tool if anyone is looking for community engagement practices. It's an evidence-based intervention, and it's absolutely phenomenal. And I also have a consultant that I can refer you to if you need some help. Another one of our initiatives is the Community Hub, which is an absolute COVID-19 pivot. So we started coming together with other local organizations like the Department of Social Services, even the police department. We have another organization that I'm blanking on the name, Cora, that works with getting food to families. And so we have come together to organize these days in the community where people can drive up, they can get masks, they can get information, they can get food, they can receive a number of things, whatever agency wants to be present. And so we've been routinely doing these in areas with high numbers of people of color. We've been doing it in communities that have higher level of risk based on income and you know, all the things. And so that is our community hub, and we hope that going forward, it will be something that we can continue to modify and make it a place where we can continually engage with the community and build rapport. Our next initiative is Equity for Moms and Babies Realized Across Chatham. Project Embrace is a collaboration between Piedmont Health Services, Chatham County Public Health Department, the Alliance, and Chatham Hospital. And so what we are doing is coming together to really create equitable processes within the new maternity ward at Chatham Hospital. Hasn't been one there for 30 years. There's actually the first baby that was born about a month ago in Chatham in 30 years, so it's pretty amazing. But what we wanted to do here is make sure that we are transforming the delivery of services so that we are serving women of color in the best way possible. We know without a shadow of a doubt that there are differences in outcomes, there are differences in birth weights, in traumatic experience, there are differences in just outcomes based on how Black women are interacting with systems. And we wanted to make sure that as we are opening this maternity ward, as we have a variety of students coming in who are also learning, doctors, nurses, everyone, that we are making that we are being intentional about how things are being done, from addressing implicit bias, addressing internal structures, and also working to fully understand the perception of the medical system from residents in Chatham, because we know that historically, there has been harm that has been done by the medical system to communities of color and other marginalized populations. And so we have to be cognizant of that. We have to transform the way that we engage, and we have to interact in a way that doesn't dismiss this and just try to pull you in, but is willing to have that conversation and ensure that you feel the best about how you're going to receive services here. And last but not least, our Culturally and Linguistically Appropriate Services Collaborative, also known as the CLASS Committee. It started because of a grant that we were able to get from the North Carolina Office of Minority Health and Health Disparities. And it is really centered on being able to take training and development and put equity into action. So we work on helping develop policies, strategies, helping people understand what it means to be accountable once you create certain policies, going through how to get leadership on board, how to interact with leadership and having these conversations, and really being able to assess where your organization is so that you know where your starting point is. Chatham County is a wonderful place. We have a wonderful local government. We have a wonderful health department, and the Alliance is a great, great initiative. But the truth of the matter is we are still very much so in the infancy of what we're doing. We are assessing, we are learning more, we are building relationships, and we understand that this is the long game and that we're not the first people to try to do this. Equity work has been trying to be done since, I would say, 1865, probably, maybe. And so, you know, we understand that people have been chipping away at this for a very long time. And our goal is to continue to grow in our understanding of how to dismantle something to the point that my children or my children's children will not have to fight the same battle. And so this is what we're doing when we are coming together, and this collaborative is open to any and every agency and organization. And it's really about taking training and development and learning application. I'm almost done. So our last slide is about the challenges that we have. So, or not just us, but the challenges in general in doing this work. And so, understanding equity. a lot of times we are able to define equity. We've all seen the picture of the ball game and the fence and the boxes, and there's a newer picture where there's the bicycles, and then, you know, everything is equitable when we figure out how to give people what they need. And that is really just scratching the surface of understanding equity. So what we know is that it is a challenge to be able to not just say, oh, how do I just give people this and check that box? How do I transform the culture of my workplace? How do I create comfort? How do I shift power? How do I give people not just a seat at the table, but allow them to use their voice when they are at the table with us? How do we do these things in a way that it eliminates implicit bias? Essentially, and this is just me talking, I do not represent my organization at this moment. Essentially, I don't care what you do when you go home. I don't care what you talk about with your mama or whoever else. What I care about is when we come in and we are doing work and we are delivering services, that you are unable to allow those things to come into play and prevent people from getting the services and opportunities and access that they need. And that's ultimately the focus of understanding equity. Another reality is resistance. I have to be completely honest in saying that there is resistance, and it comes from many different things. Talking about race is uncomfortable. Talking about privilege is uncomfortable, but I can assure you that living it is even more uncomfortable. And so we have to acknowledge that when we are in these different spaces, when we are having these conversations, when people are looking at themselves, when they're maybe even looking at how they've achieved success, what that may feel like for folks, and understanding that it's natural, it's not unnatural to feel conflicted when you feel challenged, but it's important to know that when you feel that resistance, that you have to keep going. You have to push through, and it's not a time to stop. And another reality of doing this work, a real voice. For a second, I was like, did I put that there? I did indeed. So a real voice is making sure that people actually have a real voice. So it goes back to that whole community engagement aspect of it, where we are not just asking people to come in on the back end and we're checking boxes, or we don't want to just do a pop-up focus group, and if we get somebody, we do, and if we don't get somebody, it's okay, at least we tried. What we want to do is ensure that when we are making decisions, when we are doing planning, implementation, and evaluation, that we are utilizing the voices of the community. We want to ensure that the people that we are serving, the people that we are looking at data about, the people that we're typing articles about, that we are actually going in and getting an understanding of what is needed. One of the best examples that I can show or share about this is when you look at food programs, and they're wonderful. But there was an opportunity to do like a backpack program, fill it up with food, get it to families in need, which is amazing. People need food, but families were less concerned about food and more concerned about how do I navigate my experience of fear right now as things are escalating across the nation, and how do I navigate this with my family? And so while we're addressing things that are a physical need that are absolutely important, if we are missing the piece about how to navigate fear, if we are missing the piece about how people are wondering about how to interact with systems, then we will not fully address any issues, because I can hand you a food bag, but am I reaching everybody if I'm afraid to come out? Am I giving out food bags to families who really need them? Is it only the families who are already comfortable? Is it only the families who are already pulled in through different programs? And how am I actually finding these people, and am I actually reaching this targeted goal? And so I feel like I rambled a little bit, but we want to make sure that we get the real voice of the community, ensure that it is utilized appropriately. And that we also don't just take advantage of getting information from people, but that they're actually a part of the process, and making it long-term and permanent, a permanent part of the process. And one of the last challenges is understanding the difference between shifting power versus empowerment. I mentioned this earlier, and it is essentially knowing the difference between saying that I'm going to empower you, that I'm handing you something, that I'm in a position to just pour into people or community and make things better, versus understanding that I have to shift structures, that I have to change the way that things work. I have to change the way that things are created so that the dynamics are changing and you can utilize the power that is inherently yours, that we are no longer not holding people or systems or structures accountable for interfering with people being able to live and achieve their optimal level of well-being. So moving forward, commitment, integrity, collaboration, and cohesiveness, and sharing the work. Ultimately, you have to be committed to this work. You have to be committed to the integrity of the work. You have to be prepared to say that I know that we have to move in this direction because it's the right thing to do. And that can be very difficult. It goes along with the resistance. It goes along with kind of doing the easy way out of community engagement, but knowing that in order to do this work with integrity, I have to be committed to the long hours, the late evenings, and accommodating the needs of different people. I have the opportunity to work 8 to 5, but if I'm doing community engagement and the majority of my community gets off at 5, I can't say that I did the best that I could do by only hosting things at 10 a.m. or 12 o'clock p.m. or whatever. Collaboration and cohesiveness. This is not work that you do alone. Equity work is not a one-person thing. It doesn't sit with one community. You have to be really understanding of not placing the burden on members of the community to solely do the work, even though that voice should be centered. So you have to collaborate. You have to have a sense of cohesiveness. It's not about owning the work. It's not about maintaining power or control. It's really getting away from those ideals and building a true sense of community and a different culture. And sharing the work is essentially being transparent, understanding that people need to see that we are learning this, that we are trying, that we are making an effort. We have to share this with the community. We can't do work. We can't do assessments and all these things and keep it to ourselves and only share it from health department to health department or local government agency to local government agency. This work has to be loud and proud. This work has to be done in a way where we are just truly being transparent and showing that we understand that we're new to this, that we are gaining momentum, that we're working hard, but it's being done. And it makes a huge difference when the community knows that work is being done. Thank you for your time. I guess this will be the point if anyone has any questions. And I would like to do a slow clap for my dog because normally he barks. Like he is notorious for barking before I finish anything, so yes.
Thank you so much, Michelle. So I would just like us all to take a moment and say thank you to our presenters. That was fabulous. And you did not go too long. I know you were worried you were taking too much time, but everyone was commenting, don't stop, you're good, keep going. So fabulous. So does anyone have any questions that they would like to ask at this point of any of our presenters? Please feel free to unmute if you would like to say something or write it in the chat.
Alana, somebody had asked me privately about reconciliation and if that's an important part of the process. And I did want to share that, my organization is a big, strong believer about reconciliation. And we provide the safe and brave space in which we can caucus and unpack that mantle of racism. And, the personal impacts of this work is painful and difficult, and a compassionate safe space is where these beliefs and attitudes and emotions can be explored without fear. And having separate caucuses, we have a white anti-racism caucus and a Black Indigenous People of Color caucus. And it provides a place where white people can talk without fear of offending, and people of color can talk without the burden of rationalizing or proving their validity of their experiences. And I wanted to make sure that everybody understood that aspect of it as well.
That's great. Thank you. While everyone's thinking of questions, I think going off of your point, Corinda, I guess one thing I was wondering if you've had any challenges. I guess one thing, we've talked about systems thinking a lot in our organization, which is where everyone first has to acknowledge their part, maybe their role, that may not have been helping the overall system, right? We're all trying to do our best work, but sometimes it takes everyone stepping back and saying, maybe I was a part of the problem, even though I was trying really hard not to be. I don't know if you've had any challenges having those conversations. Those are tough conversations to have. If you have any experiences with that, you know, getting people all to the table and acknowledging that maybe we need to rethink the system as a whole.
Yeah, you know, I think that the Chatham Health Alliance is in that unique position in which we're a broad-based organization. So we have member organizations that are already coming to the table to hear about all aspects of everything. And, you know, one of the conversations that we've had is, you know, we have this health on there, the Chatham Health Alliance. But as we know about the social drivers of health, is that it's all aspects. It goes, it crosses multiple sectors. And in order for us to address the health of an individual, the holistic health and well-being of an individual, we have to address those individual social drivers, which brings in the collaboration with other organizations. And that's essential because we'll have somebody working on housing and the county agency, but we'll also have somebody working on housing and environmental health. And until we bring those together, those silos actually do more harm. They're what actually causes harm more so than if we were to, you know, and nowadays with grants seeking for collaborative efforts, that it's helping to eliminate some of those silos.
Great. We have one question at the point of collaboration for anyone to answer. We have a lot of local government municipalities, so towns and cities on the call as well. How do you see municipalities and counties working together on this issue? And if you have any examples, that would also be great.
I'm happy again. I feel like I don't want to take the mic, but let me take off my sweater. No, I'm just kidding. You know, this is what we talk about, community engagement, and municipalities and counties are people. Those are the people, the residents, the citizens of those counties. And what we try to do at Chatham Organizing for Racial Equity, and what we are helping the Chatham Health Alliance accomplish, is redefining community engagement. And it really is this concept of power and understanding what power dynamics are and how they relate to the situation at hand. And when you look at power, we talk about the concept of power for people. We have power for, right? We have power that we can empower somebody else with. And we're trying to shift that mindset, that paradigm, into more about power to, right? Like we're instead of power for, power to, we have all those prepositions that we can add to it. But what we want is for the residents to have power. So by redefining community engagement, where we are uplifting the voices of communities and people of color communities, then at that point, we are hearing from the mouths of those in need as to what is needed. And that in itself is where organizations at that point should enter in and say, hey, I do this, I can come in and help out and come to a collaboration. And that's more effective collaboration, I feel, in my opinion.
I was going to share too that when it comes to working across municipalities, working within Chatham County is the only example that I can really share. But that one, I think that people have to be prepared or ready to move into doing this type of work. And if you're not internally ready to do the work, then you will not be able to collaborate. And so part of that comes from, if you are doing work, the class committee started off as being internal to the health department. And then we were able to expand it when we were no longer under the grant. And so opening that door and allowing people a space to come in and learn and understand what it is to know or to understand better about how to apply this understanding of equity allowed people from different organizations to come in to start those conversations, to bring in their leadership, because you do need leadership support in doing this type of work. And then people were ready to engage and collaborate with CORE. People were ready to engage and collaborate with something that is sweeping across the county in different towns. And knowing that if you do that, if you get a better understanding of where you are internally, you will know whether or not you were prepared to do that type of collaboration. I'm specifically talking about equity work. And I think it absolutely can be done. And some of it can be done by starting informal dialogues about what's going on, but also coming back down to that point of transparency. Because sometimes it works a little if you don't want somebody else to outshine you. So I think that's part of how you can do these things across different municipalities and things within the county.
Yeah, for sure. It's not a linear process. It's not iterative. This is not a mathematical computation in PEMDAS. But, sorry, I have a 7th grade math person. This is my whole life. I'm now a math teacher. But, it's Dismantling Racism is an organization that's existed several years ago and has since ended their tenure, but they kept up on their website what they call the phases of equity work. And I highly encourage folks to go look at it, because even amongst us, when we're on an equity subcommittee, we think we think we're so far ahead in all of this equity work. But when we go back and we look at the phases of equity work, we realize, oh, we're still on step 1, and that's building relationships. And that's the hallmark of equity work, right? And so it's a good way to do an equity audit of yourselves and to see where you actually stand in your organization and how far you've gone or haven't gone.
And one thing I would add on the accountable care community or cross-sector partnership is kind of like what Corinda was saying with the silos being a cause of the problems, right? We treat our communities, our counties, our cities as silos sometimes, and we know that we cross those borders. We cross to work and to go play and to do other things. We have friends, so having communities working together on these issues of housing and transportation and everything else is important, because we might have members of our communities going back and forth and using different resources in other communities. So those types of thought processes and policies should be better coordinated for those communities that are typically more linked.
Awesome, thank you all. Are there any other questions? I have one other one that I'll ask while everyone's thinking. To the point of tools, so you were talking about the equity assessment or audit, I think you said, Corinda, but in general, what are maybe if folks are looking for tools, I know some of it is just, these conversations starting with the human element, but do you have any good examples of resources that you turn to a lot for this work?
The community health assessment is something that's done every 2, 3 years, 4 years, 4 years. Yeah, sorry. But one of the things that we've done as an equity organization is looked at the community health assessment with an equity lens. And we found there were some huge holes in the equity assessment. And my organization's developed a People of Color Community Assessment, which really gets in on race and really gets in on those social drivers of health. And, we were in the unique position that we had several equity experts here in Chatham County that we were able to get together and to develop this assessment. But we did use some equity toolkits, and there's several. I mean, you can Google equity toolkit plus your organization sector, and something will come up. But I think after really just sitting down, doing readings, just doing as much as you can, and doing a deep dive, and it's this concept of your sagacious mind, sagacity. It's about getting down deep underneath what's underneath the surface. But that's essentially what an equity lens is looking beyond the apparent. And for resources, for toolkits, it really does depend on what sector you're in. I know for health, we use the Health Equity Impact Assessment. That's a great one and readily available online as well. And what else, Michelle? There's several. I know Race Forward has some stuff as well.
Yeah, Race Forward is an excellent organization to go to their website and look around some of the things that they have. The Government Alliance for Racial Equity, or GARE, is another organization that provides great tools and things that you can use if you're looking for an assessment. But like Corinda said, you can absolutely Google Racial Equity Toolkit. And I think when you look over the questions that are being asked, if you feel that you are not in a position to navigate that assessment, then bring in help. That's one of the biggest things, that this is not an area where, well, if you don't know, you just keep going. It's because you can do a lot of harm. You can do a lot of harm. And sometimes when you do that, it's so very difficult to get back to a good place or space of beginning to do the work. And so using any number of the assessments that are available and looking at their questions and seeing how they apply to your organization from what you know and understand, and bringing in an outside eye can be extremely beneficial in navigating different assessments and toolkits. And I would just highly recommend, like Corinda said, doing some reading, really diving deep. And I would encourage every single person to look at their own implicit bias, because whether we like it or not, it shows up. And it is so deep in there that it's showing up and you don't think it's showing up. And sometimes you really have to check yourself. And I like to think that I am Little Miss Equity, and I have to check myself as well. And so, you know, I don't know, I think I started rambling, but if you're looking for an assessment, start with doing some implicit bias work. Take the opportunity to Google, check out GARE. If you're in local government, Race Forward. The Health Equity Impact Assessment is available from the North Carolina Office of Minority Health and Health Disparities. Oh, and utilize Chatham Organizing for Racial Equity.
Awesome. Does anyone else have any other questions for any of our presenters? Lots of thank yous in the chats. We have some other folks sharing resources, and I'll make sure to include every resource that's been shared in the chat or in our presentations in a follow-up email as well. Because I know that's we're all starting on a lot of this work, so resources are great.
And if I can just share this, I want us to remember too that we are trying to create something here that's never been achieved. And we have to recognize that we're using our radical minds to create something that's never been achieved, and something that we don't even know what really it looks like, or what we hope it looks like. And so we have to be patient with ourselves and understand that the process is long-term and slow, and that's okay. Yeah, that's okay.
And if I could share one last thing too, it is that a lot of times when we talk about equity, it becomes synonymous with race and ethnicity. And we know that race is something that when you hold for all of the variable factors, that it is one of the most salient things when you look at your outcomes. But you cannot exclude from the equity conversation all the other people who, when you think about what is a marginalized community or identity. So figuring out how to make these things applicable when you're talking about people who are differently abled. As a person who is able-bodied, one of my very best friends has cerebral palsy. It was not until I entered into that relationship that I really began to think about how I navigate the world with absolutely no concern about how to get in and out of a building, absolutely no concern about how I'm going to take care of myself, or looking for an apartment. I never was concerned about, is it on the first floor or the top floor if something ever happens to the elevator. And that's just a personal example. But looking and understanding that we all enter into this with certain levels of privilege, and you have to understand that. And when we talk about equity, you have to challenge yourself to see who am I excluding? When you think about ageism, essentially anything that ends with an ism, but when you think about ageism or you think about heterosexism, I don't know if they have one for religion, but religious dominance, I guess, I'm not sure how you describe that. But when you fall into these categories of privilege and you're doing equity work and you're still thinking very much so in your own perspective, you are still kind of missing some of those equity markers. And so I challenge everyone to look at where they are and where they sit in certain levels of privilege, and then think about, how do I take this equity work and do all of it? And it's huge. It is not a small thing. It is huge, but it is life-changing work. And that's what we're doing, is seeking to change the lives of people across the US, or, in our respective communities. But that's the last thing that I'll say.
Awesome. So I think it seems like we don't have any more questions, but I would like to again say thank you to Michelle, Corinda, and Brianne for all of their time today. One thing I will note before we close, but we're going to let everyone out a few minutes early so you can go grab lunch early, but community engagement is the topic that keeps coming up in all of our sessions as something that is just a pivotal piece of this work. And so our next session will be on community engagement, even though we're already talking about it, right? So we've already been talking about it, but the next session is specifically on that topic. So please feel free. A lot of you I know are already registered. If you're not, please join us. Feel free to bring your questions and your experiences with community engagement, because we will have presenters, but I think this is a topic that a lot of us are still discussing and learning about and doing the work on. So that's next Thursday, 10 a.m. And then the following week, we will also have a session on policing, which is another conversation that keeps coming up in all of our sessions. So thank you all for joining us. Thank you to our presenters. We will send out all these resources and PowerPoints and maybe contact information, because I think a lot of folks will want to follow up with our presenters. So thank you again. Have a great rest of your week.